Right. Oh, good. I can see lots of people have joined us. All right, so welcome everyone to our first Migraine Foundation members webinar. I'm Sarah Carl. I'm one of the co-founders of Migraine Foundation Aotearoa, New Zealand. It's really exciting to be running our first members webinar tonight. I just want to take this opportunity to say thank you to you all for being Migraine Foundation members. As you probably all know, Fiona, Suzanne and I have been running the charity for the past 2 years as volunteers, so we really appreciate the support that you've given us so far. So I'm joined tonight by Dr Rosamund Hill, who I'm sure many of you will probably know. Ros is an Auckland neurologist and one of only a few migraine and headache specialists in New Zealand. Ros is also a member of our clinical advisory group. Ros works in both public and private. I'm fortunate to have Ros as my neurologist. Ros is also my mum's neurologist, and Ros has also offered me advice about my son's migraine as well. So welcome, Ros. Thank you so much for volunteering your time tonight. We appreciate it, and I know our members appreciate it as well. So just the format for the evening is just really a question and answer session. So our members have had an opportunity to submit questions prior to tonight, which received a bunch of. People also, you're welcome to type a question using the chat function. If you can find the chat function down the bottom of your screen, you can pop some questions in there as they come up, and hopefully we will have time to answer the questions. I see Peter is saying hi. Hi, Peter. So, Ros, first question. So medication overuse headache is something that lots of people ask about in our support group. We've been asked, how do you know you have medication overuse headache? What does it feel like? And is it different feeling to a migraine attack? And I guess tips for managing it and what to do if you do have medication overuse headache.
Excellent question to start with. Can you hear me okay?
I can, yeah, I think.
Okay.
I can.
Okay, so quite a tricky question, because there's no doubt there are some people who have headache sort of every day or almost every day, and they take medication every day, and their headache is not caused by the medication. But there are a lot of people who over time have had headache that's now and again and seems to slowly get to become more frequent. So they're taking the medication, the headache is becoming more frequent, they're taking more medication. And at some point, it tips over into the amount of medication you're taking is now aggravating the situation. So it's not an absolute thing that everybody who takes medication every day, if they stop it, their headache will get better. There are some people who will stop it and they're still having headache every day. But what you don't want is that the medication has transformed your headache problem from now and again to headache all the time. Now, you asked about the nature of the headache. So it's quite variable. So if you take your rizatriptan or sumatriptan on average more than 10 days of the month, you can trigger more headache that will look the same. So you can trigger more migraine that will look and feel to you the same. Or you can actually get headache that you recognize as migraine but is different and can be worse. So it may look just like your regular migraine, it might look a little bit different. If you take a lot of paracetamol or a lot of anti-inflammatories, you can end up with just a sort of mild to moderate persistent background ache that is just there all of the time. And then when you stop the Panadol or the ibuprofen, you can find you now have a clear head for some of the time that you didn't have before. So the answer is it's difficult to tell, and the headache can be quite variable. All we know is if you keep your triptan use and your simple analgesics, which is what I call the Panadol and the ibuprofen and the Voltaren, if you keep them under the recommended limits, you can be comfortable you're not making the problem worse.
Yeah.
If you look at how much you're taking and it's over the limit, then it's worth thinking about, okay, maybe the medication is making my headache worse. So what you need to do is often keep some records so you can count how many days, and it's the frequency, not the total dose. So you're counting the days that you're taking triptans, the days you're taking Panadol and anti-inflammatories, not how many triptans you're taking. So you're counting the days. So whether you take the Panadol once in the day or 3 times in the day, you're just counting it as one day.
Okay.
And the same with the triptans. So, and they overlap. So if you're talking about triptans, the magic number is 10 days per month on average.
Yeah.
So that means it might be 12 days 1 month, 8 days the next, 9 days the next month. That's still on the 10-day average. You're probably okay. And the anti-inflammatories and Panadol, they're overlapping. So what I usually say is you need at least 15 days in the month, no Panadol, no anti-inflammatories, no triptans. But on the other 15 days, you could take the Panadol and the anti-inflammatories, and 10 of those days. Now, if you say, well, I don't take paracetamol or anti-inflammatories, I take those 9 days a month, say, not nowhere near the 15, but then you take your triptans on another 8 days of the month, you're at risk of getting into trouble, because overall you're exceeding the 15 days a month, even though it's some of one and some of the other.
Yeah.
So yes, you've got to look at both of them individually, but you've also got to look at the combined and look at how many days in the month you're not taking those pills. So you need 15 days a month with none of the what we call acute treatment, which is what you take when you've got a headache, as opposed to preventive treatment to try and get fewer headaches. The other thing is this problem develops generally after about 3 months. So say you have to have a knee operation or you fall over and have an injury, can you take your Panadol and ibuprofen regularly? Well, yes, you do have to, and that's the right thing to do. So this problem develops generally when it's more than 3 months of overuse, not straight away.
Yeah.
And you see that quite often with someone who's had a concussion and then they've got bad headache that persists. You've got 3 months in which you can take things regularly, but after 3 months, you want to be counting the days and make sure you're under those limits. So what do? Well, you've got a few options. You can just go, oh, I didn't realize, I'll just cut them back. You don't have to completely stop them. So you don't have to go, well, I can't take any at all. You can just get it down under those limits, and that's a perfectly reasonable thing to do. We used to say, well, you need to just stop it altogether, and there's been some debate about it, but I think the general understanding is you'll improve things either way. Either if you stop it altogether, say, okay, well, I'm not going to take any and going to have a break for a month, or whether you say, I still need to take some, but I'll keep a track of it and I'll gradually get it down to under that. And the other way you'll generally do that is to look at either adding a preventive drug or adding another preventive drug or changing your preventive medication, because that means you're not being managed adequately if you're needing to take it that many days a month. So you might need to add some prevention, add some more prevention, change it. Yeah.
Because it's tricky, isn't it? Because once you get in that cycle, it's very hard. If you're needing those medications to function every day, then so people should be looking to start preventives or or change their preventives if they are doing. And if a couple of months you went over and then a couple of months you went under the limit and over, does that still have a bit of a
Yeah,
risk?
so it's an average out.
Yeah.
So you might have a few months where it's a bit more than that, but as long as you keep in mind, okay, I've been taking a bit much, I need to keep some records, I need to get myself back under the limits. That's why it's that many days on average
Yeah.
rather than an absolute every month. And you might have other things that come along, as I said, that mean that you hit a rough patch or some other health issue, because your body doesn't know whether you're taking it for your head or for your sprained ankle.
Yeah.
You can still get into trouble, but you may need to take it for a while for something else. That's okay. You just need to be aware of getting yourself back on track
Yeah.
over time. Yeah.
It's tricky. There is a lot of conversation about medication overuse. Another question we got was, can you explain about a greater occipital nerve block as a treatment option? How effective is it, and any drawbacks and side effects? And I think maybe also adding that, like, can people actually access them in New Zealand as well? And where, if it's an option, how can people access them?
Yeah. So the way I think about a greater occipital nerve block, mainly because it's a tricky thing to do as a regular ongoing treatment. So it's not something that typically we would say, okay, you could start this preventive drug, or we could regularly do a greater occipital nerve block. It's more, this person has got into a bad place, they're getting really bad, a lot of headache. Can we do a greater occipital nerve block to just kind of break the cycle and try and settle things down? So we'll often do it if someone's had a bad patch with medication overuse headache,
Mhm.
or they just have got a really bad flare, and it's like, what do I do? I've kind of run out of options. How do I kind of get things back on track? Then you might do a greater occipital nerve block. You can do it for any kind of bad, frequent headache problem. You tend to think about it more often when the pain is actually over the back of the head, but
Okay.
you can use it even if the pain's not at the back of the head, because you're modulating the input from the greater and lesser occipital nerves, which spread up over the back of the head. So you're hoping by blocking those temporarily, you're having some influence on the input to the brainstem and where the generator of the pain is going on. A bit like the Botox does as well.
Mhm.
You're trying to modify the input that's coming from the head and the neck to try and settle things down. So the greater occipital nerve block can either be just local anesthetic, just like
Mhm.
ordinary lignocaine, like you do if you were going to anesthetize somebody before you stitch something up. It can be either that on its own, or that plus some steroid. And that's the same steroid like, you put into a joint or something like that. So the sort of the injectable equivalent of prednisone,
Mhm.
which is essentially a strong anti-inflammatory. So it's kind of a non-specific treatment for head pain, basically.
And
Yeah,
and
not
can,
specific for one thing or another.
yeah.
Used quite often in cluster headache. When the cluster starts, sometimes you can just interrupt the cluster by doing a greater occipital nerve block. You usually do it on both sides of the head, but if the pain is always only on one side, and you really don't only want 2 injections and not 4, you can do it on one side, but often we'll do it on 2. One injection over the greater, one over the lesser, and it leaves you with a numb back of the head for about 12 to 24 hours. That's the
Mhm.
local anesthetic. Just tells you basically you've got the right place. You've
Mhm.
you've hit the nerves, you've anesthetized the nerves, it's gone numb. But that's not really um, what the treatment is about. You're not trying to make the back of the head numb. That's just a sort of a byproduct. And if you use the steroid, you can only do the steroid every 3 months. If you do it
Okay.
more often than that, you can get a local effect, what's called skin atrophy, where you inject it, and the skin sort of the fat underneath the skin shrinks away, and you get left with a bit of a dip.
Okay.
So typically, you only do the steroid injection every 3 months. You can do the local anesthetic injection every 3 weeks. But again, that's why it's not really a very practical option in
Mm.
terms of somebody having to inject it every 3 weeks or whatever. It's not very practical.
'Cause who does them? Like, if people are
Oh,
looking at, is it just neurologists or?
well, actually, no. Pain specialists will do them. It's actually very straightforward. GPs could do them. And if the GP was interested, there's a really great little YouTube video. Don't try and do it yourself because it's the back of your head or to your friend.
Yeah.
But there is an excellent little YouTube video from a guy in San Diego who so it's very straightforward. So you could ask your GP, but they might not. Depends. If you've got a GP who's kind of quite proactive and likes injecting things, would inject your knee or your shoulder or whatever, they'd probably be perfectly able to do it. But I do it in the hospital, but most of the neurologists don't do it. Though I'm busy teaching other people, it's very easy and very
Mm,
safe. Like there's
mm,
no real risk or side effect of it, because unless you're allergic to local anesthetic, and most people will know whether local anesthetic's a problem, and nobody generally has a problem with local steroid injection. So it's actually extremely safe and quick and easy to do. So the problem is more that it's not really a practical long-term solution. And how well does it work? Well, it's a bit random. As to how well it works. Some people it works extremely well and it's reasonable to do it from time to time, but it's not something we use sort of in our regular armamentarium of, okay, well, you could try this drug, or let's give you this nerve block every 3 months, mainly because of the practicalities of somebody doing it every 3 months. But I certainly have some patients that actually it's a really good option, very safe, inexpensive.
mhm.
So yeah, it's definitely worth considering, particularly if you get into a really bad place.
So that's what,
It's
if
a good
maybe
thing.
it's just, yeah, breaking that cycle if
Yeah,
you've tried lots of things and this is the another
yeah,
thing to
yeah,
try.
yeah. That
Yeah.
might just give you 3 weeks or 3 months of some improvement. Yeah.
Mm, okay. Good for medication overuse, is it?
Yes, you could well use it in that position. Exactly right. Yeah, yeah. These
Okay.
days, when we try not to admit people to hospital for the IVDHE, which we used to do from time to
Yeah.
time, because it's just so difficult with how overloaded the hospital is at the moment, and the idea of going to hospital for 3 or 4 days is not really practical for most people anyway. So if you can do some Botox or greater occipital nerve block to try and just sort of break the cycle and improve things, both of those are much better options.
Okay. Yep. No, that all makes sense. Traveling with Emgality, is it okay to take a dose a few days early or late to fit in with travel? Is that another?
Absolutely,
Yeah.
absolutely. So, and I think it can be. I know they say with Aimovig it could be out of the fridge for 2 weeks. So I don't think there's a major drama if you're going from A to B that you have to necessarily travel with a little chili bag for it.
Mm,
But it's perfectly fine. So when they did the trials of Emgality, they did 120 and 240, and there are some patients who better with 2 injections.
yeah.
And there's some patients who are doing theirs at 3 weeks.
Okay.
So there's no problem with the dose being, so if it suits you to do it at 3 weeks and because you're going away, or even at 2 weeks, doesn't matter. Absolutely fine. Yeah,
Yeah.
yeah. So I probably wouldn't exceed 2 injections every 4 weeks. But you can do 2 injections every 4 weeks. So if you're doing one injection, however often, it's not a problem.
Okay. Okay. And I think I believe it's 7 days out of the fridge for
Is it
Emgality.
for Emgality? Yeah.
Yeah.
Yeah, so it's
So,
not as much of a drama as you think,
yeah.
yeah.
So I think someone just asked, is it okay, yeah, to stretch it out the other end? So if you
Oh,
if you
okay,
were
yeah.
traveling and it was 5 weeks as well, that's okay. It's okay to
Oh, absolutely
have
fine,
the
yeah,
dose
yeah,
of it. Yeah.
yeah,
Yeah.
yeah. The half-life of the drug technically is 27 days, which means half of it will have disappeared by 4 weeks. But some people, if you can stretch it out, it makes sense just from the financial aspect.
Yeah.
If you can do it every 5 weeks or 6 weeks or 7 weeks, it also means, I think, if you're not sure whether things have settled down and you're wondering whether you could actually withdraw it or take a break from it, the
Yeah.
logical thing to do is to spread it out. And just see if you did it every 5 weeks and then 6 weeks and 7 weeks, whether in fact you can avoid having too much of a recurrence of your migraine. There was a trial done in Germany where everybody who was on the trial took it for 12 months, and then everybody stopped it and they monitored them. And you can see over the next 3 months, things sort of went back to where they'd been before. And
Okay.
then you restart again, yes, with 2 injections if you restart. So if you've taken a 3-month break,
Yeah.
yeah, you could restart with 1. The problem is if you do 1, it'll take you 4 or 5 months for it to get up to where it was, back to full dose. So people can choose when they start it to do that, but it will take you 4 to 5 months, is what the drug companies say, till you'll be at a sort of therapeutic level. Whereas if you take 2 to start, you'll essentially be at a therapeutic level after 1 month.
Okay.
Yeah.
Yeah. So what was that? So after 3 months, if you've had a 3-month, it's probably
Yeah,
best
so
to
if you
double dose.
decide to just stop it altogether,
Yeah.
then the overall impression is that the migraines are likely to slowly over the next few months, sort of over the next 3 months, are likely sort of to come back to maybe where you were before. Not necessarily everybody, but overall that's what happened if you take a whole big group of people, that then over the 3 months they slowly came back up to kind of where they were before. So then if you wanted to restart, I would say yes, do 2 to
Yeah.
start,
Yeah.
so that after 1 month you're back to full
Yeah.
dosage level.
I think if everyone's like me, they don't want to risk it. They'll just keep going every
Yeah.
28 days and go, oh, yeah, don't ever want to stop. So
Yeah, exactly. Yeah.
There was a question coming in about, is there an update about funding? There is not. From what we put on our website in January, that's our latest funding. It's still with PharmAC, so it was recommended for funding from the Neurological Advisory Committee, but we haven't got a further update from there. Another question. I've read that some medications such as nortriptyline, amitriptyline, and gabapentin have been linked to higher risks of dementia. Can you comment on this?
Not particularly, no. I don't think that's anywhere a solid or strong link, or something at this stage I would even discuss with patients or consider with using the drug. So no, I think that's one of those loose associations that is talked about, but no, it's to me the use of those drugs, amitriptyline, nortriptyline, and gabapentin and pregabalin, that if they are significantly improving your headache problem, that's better for your overall general health and longevity. I think it's very important to withdraw drugs when they're either not working or you're not certain if they're working. So I think it is important. I think doctors often forget and just keep rolling things over, and don't necessarily look at things and go, is that actually still working? So I think it is important, if you're not certain, to very slowly withdraw drugs, and you want the lowest dose of something, because we don't know with a lot of drugs what the full picture might be. So I think you want to be sure the drugs you're taking, are they working?
Yeah.
Are they sufficiently beneficial to keep taking? And if you're not sure, slowly withdraw them.
I think we wrote an article last year, and it was kind of a recommendation saying once a year maybe check in with your GP and discuss all your medications, to exactly what you've said. Are these working? Is there anything different? Would that be something, would you recommend people kind of once a year with their GP go through medications?
I think so. Yeah, I think GPs are very, very busy,
Yeah.
and they'd like you to come with one problem. They don't want you to arrive with more than one issue to discuss in the 15 minutes.
Yeah.
So I think as a patient, it is actually a bit of our responsibility to realize that there are a lot of things that we've got a lot of issues. it's that we have to think about some of them ourselves and say to the GP rather than relying on the GP to think of it. And if the GP thinks everything's going fine, it might not cross their mind. And they also, you have to often look up to see how long somebody's been on something, so sometimes you just do stay on something because you feel okay and you think it's doing fine, but in fact, maybe you no longer need it. So yeah, I think it is important. Yeah. I can see Fiona's having a little chat about
Oh,
Aotearoa.
yeah.
I met with the AbbVie people, I think, last week or the week before, but it's still not through MedSafe, according to them.
Oh, really? Yeah, I know that. I mean, MedSafe has got 15 or 16 steps to get medication.
Yeah. So that's what they said the other day, is that it hasn't got the MedSafe, because I was asking about it and the cost, and they said they can't really say until it gets through. But when it gets through MedSafe, I think they are looking at bringing it in.
Yeah. Oh, that's good.
So that, yeah.
It'll just
Yeah,
depend
no,
on.
it's a very interesting drug.
Yeah.
Yeah, so talking about medication overuse headache, those new drugs, those oral CGRP blockers, don't cause medication overuse headache.
Yes. Yeah. And some you can use acute, and some you can use for
Some
both.
you can use acute, some you can use as both, and those ones don't cause rebound problems. Yeah, which is another thing. The other interesting thing about talking about the new drugs is that I see that in the US, they're now approved them and recommend, their guidelines for first line treatment.
Yes. Yeah. That was a few months ago we saw that. Yeah.
Yeah,
So,
the European and now the US.
yeah.
The Europeans did first, yeah, but the US as well. Yeah.
Yeah. Positive steps.
Yes, yeah. You've got to think all of that shift and drift towards the new drugs has to generally push things in terms of, we need these to be available. Yeah.
Yeah. And we will keep advocating for all of them as we have been. Another question: how do I prepare for a GP or neurologist visit so I can get the best out of it?
Great question.
What do I need to bring, and what information do they need to make sure I get the right diagnosis and best treatment? I mean, I guess there's two parts to that. So many people in our community aren't fortunate enough to see a neurologist, so they see their GP, and often that's enough. So if
you can if you do some preparation and go and see your GP, you can make a huge difference. And in fact, it's not going to be much different, I don't think, to seeing a neurologist if you've done some prep work before you go. So what you want to be able to tell the GP, so there are a few bits. You want to be able to give the GP a concise history of your migraines, when they started. The things that I want to know: when did they start? The circumstances of them starting. Did they start when your period started, or when you were pregnant, or things like that? Sort of what age and the circumstances. Then you want to know the description of what a typical event is like. So my migraines always begin with pain behind my left eye, and it spreads a bit to my left temple, and the light bothers me and the noise. So a bit of a description of this is the headache problem that I have. This is the frequency of it. So it depends on whether you come in with a diagnosis already, or you're wanting a diagnosis for what you've got. Let's just say you've got migraine, you've read about it, you think that's what you've got, and you're looking for, okay, I want advice on treatment or better treatment. So then what you want to be able to tell the person is how long they last for, how often they occur. The other thing that's going to be most important is how you currently treat them. So what exactly do you take, and when do you take it? And then in the past, what have you previously been prescribed? And not just, I've been on amitriptyline. The question is, what dose of amitriptyline did you take? How long did you take it for? Did it work? Did you get side effects? Because you want to know, okay, the GP gave me propranolol in 2015. It dropped my blood pressure. I felt very dizzy and I stopped it. So it's like, okay, now you know exactly all you need to know. there's no point in necessarily doing that drug again. But if someone says, the GP gave me amitriptyline, I took 10 milligrams for a week, didn't do anything, and I stopped it, then you're like, okay, that's back on the cards again, we can consider that. So the person who's making a decision about treatment actually needs those details. And sometimes if you ask the pharmacy, if you've been to the same pharmacist, you can just ask them to look up in their records and tell you what you've been on. Like, has anybody ever prescribed me, whatever drug it is, and that the pharmacy, or just ask the pharmacy to tell you which of these migraine drugs that I looked up on the Migraine Foundation website have I ever been given.
Okay.
The GP should have all that information, but in your 15 minutes with the GP, they are not going to necessarily be able to pull out all that information. But if you can say, okay, I've tried 3 preventive drugs in the past, this one, this is what happened, this one, this is what, then you're a lot further along in terms of the person going, okay, I'll look on the health pathways guideline and see what options there are that you haven't tried.
Yeah.
And let's try one of those, because that's what the neurologist is going to do as well. Not necessarily look on the health pathways, but they're going to pick one of those drugs. So, and you can even look at the information the Migraine Foundation provides and say, actually, I haven't tried that drug. That sounds like a good drug, because actually, I might lose weight on Topamax and I've never had kidney stones, and that sounds like a good drug. So you could actually go to the GP and say, I've tried these, I've looked this up. This looks like would be a reasonable option for me. Can I try this? So there's actually, if you're being proactive, you can actually do a great deal that will actually advance things.
And headache diaries are key, aren't they?
Yes.
Way? Like, yeah.
Hugely helpful, yes, because mainly because nobody can generally remember accurately unless you have headache every single day. And those people, sometimes keeping a diary is just too much.
Yeah.
But if you have episodic headache, it is much better to keep some records. And then also when you go to the GP, you can say, okay, this is the last, 2 months, and these are my, migraines. These are the days I've had headache. This is what has been going on. It's just all that information, because the GP needs or the neurologist needs quite a bit of information to use to make good decisions.
Mm.
You know.
Yeah. No, all makes sense. Any tips for menstrual migraine? I know menstrual migraine.
No,
menstrual migraine. I was going to say, is it worth knowing that your period is coming up? Is it worth like preloading with medications in the days before or after, or like what's it? Because I know they're really tricky to treat and often can be hard ones. What are your
It depends on if your cycle is regular. So if you get menstrually triggered migraine and your cycle's regular, that's really helpful, because then you can anticipate more or less when it's going to come, and so typically you can come up with a little sort of 1 week of treatment that you start 2 or 3 days before you expect that you typically get your migraines.
Mm-hmm.
So if you say, I typically get my migraines a couple of days before my period arrives, then you might start it 2 or 3 days before that and continue it for a week. And then it's a matter of experimenting with what you're going to use for your little mini prevention program. So it might be a triptan, that would be fine, but it might be regular paracetamol and anti-inflammatory, or both. It's a matter of, so you can pre-treat like that. The problem is that if the fundamental issue is the hormonal fluctuations, you may also want to look at, can you get rid of the hormonal fluctuations? So the sort of more effective way is not to have any periods. And sometimes that is the best solution. Okay. So it depends, because not everybody wants to take hormonal treatment to stop their periods. And if you can get away with just some prevention, that might be absolutely fine. So I think you want to consider both options, is getting rid of your periods, so getting rid of those fluctuating hormones, or a short, particularly if you've got unpredictable periods, then you never know. And then by the time it started, then the migraines hit. How effective is the treatment?
And is that something that you could manage with your GP, or would that be that you would be
Start
getting?
with yes.
Yeah, they could help you start that. Like, it's not requiring a referral to a.
Not necessarily at all. No. It also depends on sort of whether you're in the sort of reproductive period of life where you've got regular periods but you don't want to get pregnant, or are you sort of perimenopausal, depending on what you're wanting to do with the hormonal treatment. But the GP will often be able to start with things, maybe not the sort of bigger guns, but certainly the GP could start, and the GP should be able to do almost all of the stopping your period options. The GP should be able to do a lot of those. The hormonal manipulation, the GP will be able to do some estrogen patches, things like that. The GP will be able to manage some HRT. The GP be able to do all those things. Yeah. And that's where the records are really helpful.
Yes. Yeah. So rizatriptan is designed to be dissolved on the tongue. If I don't like the taste and want to swallow them with water instead, is that okay?
Totally fine. Yeah.
Okay.
So rizatriptan is not absorbed from the mouth or the tongue or the throat. It's absorbed in the small intestine. It's designed to dissolve just to try and make it get in faster.
Okay.
So it doesn't matter at all. So no, if you don't like the taste, just swallow it, or put in a bit of yogurt or something. Yeah, no, don't have to dissolve it. And it can be, people often say under the tongue, but typically they just put it on the tongue. It dissolves very quickly, but no, a lot of people don't like the taste.
No, I can leave
doesn't
the taste.
have to be dissolved. No, Zolmitriptan, the nasal spray that we used to have, which also didn't taste that great, that was absorbed from the back of the nose and the throat to some degree, but the rizatriptan, no, that's just a dissolving trick.
Perfect.
All good.
Perfect.
One more comment about the triptans. If you're trialing sumatriptan, it's important to try the 50 and the 100. So one or two tablets, because often people just take 50 milligrams, but you want to make sure that you try both of them. And the other thing is not to forget about the injection of so if you're someone who says, well, neither of those work for me, make sure you've tried 2 sumatriptan tablets, that's 100 milligrams, and make sure you've asked the GP about the subcutaneous injection, because some people, that's the only one that works, not the tablets.
And I'm assuming that you would still, if you're having like the cluster injection, sumatriptan injection, that would still be classed as a day that you're having.
Yeah, that's
triptans. Yeah.
Yep, that's
And it's interesting. I think one thing you said very early on that I think a lot of people, there is some confusion about, is that you're saying you could take 3 triptans a day for 10 days. So some people will go, I can only take 10 triptans in a month, but it's the actual
people do. It's the dose. It's the frequency, not the dose. So you count the days. So if you take it in the morning or sometime and then it wears off and you feel it coming back, take it again. We count that as one day. Yeah.
And that's why you want to, if the strong ones work, you want to be taking those strong ones to get on top of it. Would that be right? That you were going, hit it as hard as you can for a couple of days.
There's definitely, you've got to be very careful of the false economy of going slow at the beginning. So generally with treating acute migraine, the policy is hit it hard. And the other thing that often the headache, big gun headache specialists say is, you want to use the right drug for what you're actually treating. So if you know this is a migraine and you know triptans work and you're not at the overusing edge, don't be stingy about, I'll just try and see and wait and, see what happens. I'll take a couple of Panadol and just wait. If you know this is a migraine and the probability is this is the way it's going to go, don't be sort of positive and hopeful, you're better to just actually treat it aggressively, because you're likely to have a shorter duration by doing that, and in the end less medication than if you sort of inch it in slowly and then you end up in a worse place. So you want to be clear whether you think this is definitely a migraine. I mean, it might just be a mild headache, in which case you might say, I'm going to try some mild medication, because I don't know. But if you're like, I know this is going to go bad, but I'm just going to keep my fingers crossed and, just take a couple of Panadol and keep going, yeah.
And antiemetics as well. I know that I use those as well. Yeah.
So I'm optimistic. The thing about antiemetics, some antiemetics have some anti-migraine properties for sure. So metoclopramide, prochlorperazine, even promethazine, they on their own have some anti-migraine properties. Ondansetron doesn't. It's just a good anti-nausea drug. But it's really important to improve the gastric emptying, to avoid the nausea, for drugs to be absorbed orally. So yes, definitely don't ignore the nausea for sure.
Yeah. And even if you don't have nausea, having an antiemetic.
Well, it's worth trialing it. So what is worth doing is using 10 milligrams of metoclopramide with your anti-migraine pills sometimes and not other times, and see does it actually make any difference, because you may find actually that you do better if you take it. So it's worth experimenting and just seeing, because everybody's a little bit different, so you do need to just figure out for you what is the combination that works well.
Thank you. Just another couple of questions we've got. It says, I have chronic migraine, but I haven't been able to get an appointment with a neurologist in the public health system. My GP doesn't know what to do next. Any advice? It's a tricky one.
Well, that's what I would probably do then, is take it a bit into your own hands and get onto the Migraine Foundation website and read about all the different treatments, because the treatments that are not drug treatments, etc., the lifestyle treatments, exercise, sleep, and all of the rest of those things, a lot of those you're going to figure out yourself. So what you're relying on the doctor for is the prescribed things. So that's where I think that if you do some research yourself about all the different drugs that are available and treatments, read them all and go, well, I haven't tried that. When the GP sends a referral to the hospital, to the neurology clinic, and the letter comes back to the GP saying, we've got too many people, we're not going to see you, they will say to the GP, you need to look at the health pathways. Now, I'm about to review the health pathway that we've got. I've spoken to the health pathway people to make it a little bit more accessible for GPs. But fundamentally, the GP, between you and the GP, you're probably able to do just about anything that the neurologist would do, short of Botox or greater occipital nerve block. But almost anything else in terms of the management, between what you can look up yourself, what the GP can read about on the health pathways, you should be able to try all of the available funded treatments, or even Emgality, without any input from a neurologist.
Okay. Okay. One final question that we had. Is there anything new on the horizon for migraine other than the CGRP medications?
Well, there are a whole lot of devices which we don't have easy access to either, which we don't talk a lot about because they're expensive, and overall they're sort of more add-on rather than standalone things. And I don't have a lot of experience with those because we don't get them very easily. So that's the Kefali device, and there are a variety of other things. They get FDA approval much more easily, so there's nowhere near as stringent need to show a benefit as there are with the drugs. There are quite a lot of other drugs in the pipeline. So the CGRP drugs, like the two we've got, are then being followed up by the Gepants, which is like a Tadjapant. they're oral drugs that block CGRP. There are other oral drugs, lasmiditan, I don't know how you say it.
Yeah.
That one.
Yeah.
Yeah.
I say ditins, but I don't know if that's even the correct way to say it.
So there are other families of drugs that are a bit like sumatriptan, rizatriptan, that target other receptors. We don't have those either. So the main thrust for the future of migraine treatment is going to be the CGRP drugs, both injected and oral, because the oral drugs in the US, I think they've got 3: atogepant, ubrogepant, rimagepant, and they're all slightly different, and some are used intermittently, some are used regularly. And they can be used with the others as well, with the injectables. I think that's going to dominate our migraine management for quite a long time. Cheaper than Emgality? No. No. Emgality in New Zealand is probably the cheapest anywhere in the world, apart from if you've got a drug company that's going to, if you've got a insurance company that will pay for it. And Southern Cross say they don't pay for it because it's not funded by Pharmac, but so I don't know whether that means when it does get funded, will they fund it? So if you get a special authority, that means you've got limited access to it. But then can other people get it on their health insurance? That will be interesting to see. Yeah, these drugs are all expensive. That's the problem, mainly because they've had so much time in research and development that they can't be cheap, because they've got to recoup the billions of dollars in the trials. Yeah.
Sumatriptan, when I think it first came to New Zealand, was about $90 a pill or something, wasn't it? And
it's about $50. Yeah, people used to fly from Australia to get it here. Yeah. It was literally $50 a tablet, I think. Yeah, it might have been more. Yeah. That was 1990, I think it came out, which is
So those are all the questions that we've had. I'm just still got a little bit of time. I'm just reading through the comments. So if anyone's got questions that they want to put in the comments.
Put something up about neck trouble.
Yeah, there was. It said neck problems. A lot of my current problems these days stem from my tricky neck. I see an osteo who is about me relief, but this tends to be every 2 to 4 weeks and takes a lot of time out of my work day. Sometimes in maintenance, sometimes with my headaches. I've been taking 35 milligrams of amitriptyline as a muscle relaxant for a few years. Any thoughts on this?
Yeah, so the relationship between neck pain and migraine is a tricky one. And part of that is related to the anatomy, which means the nerve supply of the upper part of the neck and the brain all end up in the same place. So when a migraine is activated, when it starts, you can get neck pain either as the first symptom or at the same time as the headache, or later in the course of it. So neck pain occurs in a lot of people with migraine. And if you happen to get the neck pain first, the problem is it's going to make you think there's a problem with your neck. And a lot of people will have muscle spasm that occurs as part of their headache and what's going on. So getting osteopathic physiotherapy, chiropractic input is going to feel helpful. But the issue is, are you treating the cause, or, it's a bit of a chicken and egg situation. But I think for a lot of people, the muscle spasm and neck pain is secondary to the migraine process. It's not that there's something in your neck. There are some people who that's probably not the case, but I would say the majority of people get neck pain with their migraine, and it's not caused by a problem in their neck. That's not to say having some physiotherapy input doesn't make it feel more comfortable, but in my experience, it's uncommon that it fixes the problem. So it's often temporarily makes you feel more comfortable. It's temporarily helpful, but the issue is, does it fundamentally fix the problem? And often not. So you've got to be careful about spending a lot. I'm always reluctant people spend a lot of money on physio and osteopathic input over a long period of time, but it's not fixed the problem. So I think it's a trial and error situation, but it's not like one should be going to get that input if you've got neck pain with your migraine, because it may not be, may not make any fundamental difference. So
Yeah.
if you go and give it a try and you're like, wow, that fixed me for months, fantastic. But I wouldn't be surprised if you did that and it's like, yes, I feel more comfortable for a while afterwards, but then it comes back. Then it's worth taking note of that and going, okay, well, is it worth keep doing that, the cost and the time, etc.
It's like triggers, things that you thought were actually triggered an attack were actually symptoms of the migraine and the prodrome. So it's like that, isn't it? So
exactly. So if you start with pain in your neck before the headache starts, and lots of people do, one side, the back of the neck comes up and then into the head, you're going to naturally think, well, this must be where the problem is, but that's not necessarily the case at all. In fact, most of the time it isn't the case.
Tricky.
And you can often tell, because if you take the sumatriptan or the rizatriptan and the neck pain goes away, then logically that's going to tell you actually, yeah, it's the migraine.
It's migraine. We've had another question. So it said, I have 10 to 15 consecutive days with migraine, then 4 to 5 days with no migraine, or sometimes just 1 to 2 days without migraine. Is this medication overuse? I've had migraine since the age of 8. I'm now 74. So yeah.
It'll depend on what you're taking in that day when you've got a run of them. So you're at risk of getting rebound from triptans, I think, if you take it more than 3 days in a row. So I generally would not say take triptans more than 3 consecutive days, because I think you can then get into a run. So you've got to be very careful, I think, taking them that many days in a row. So typically I would then switch to taking a decent dose of paracetamol and anti-inflammatory on day, 4 or 5 if they carry on. So yes, you could be, if you're taking triptans for that many days in a row, you could well be getting a rebound situation. Yeah.
And is that going back to, if you are taking them for that many days, is it time to look at something else, a preventive or something, or some other? I mean, I know we don't have a lot of devices or things like that, but yeah.
Yeah, that sounds like you're likely to have too many days in the month of migraine to be able to manage it with just treating them when they come. Yeah.
Got one more question coming, I think. If anyone else has got any other questions, please put them on. I think we've got a few more minutes, about 5 more minutes, and then we'll let Ros go. Finish the rest of your dinner, Ros, or
It was a long clinic this afternoon and a wet, rainy Auckland day. Is there a difference between rebound headache? No. No, so the technical term is medication overuse headache.
Yeah.
But fundamentally what it is an overuse rebound situation. Yeah. And one of the things about that I think sometimes is a little bit insightful is that you wake up every day with a headache, and then you take the medication and it improves somewhat. And I think sometimes that's you haven't taken any of it, or you haven't taken any Panadol or Nurofen through the night, and then so you wake up with the headache. So then you take some Panadol, Nurofen, and it improves. So you're kind of treating the withdrawal, that you haven't been on the medication. So often it's a headache people will wake up with in the morning. Yeah.
Okay, well, I know there haven't been any other questions, so I mean, thank you, Ros. It's always fantastic. I know a lot of people don't get to speak with you or speak with neurologists, and it's been fantastic that we can, our members who have been big supporters of our organisation over the past year, get a chance to listen to you and ask questions. So thank you everyone for attending, and thank you, Ros.
Oh, it's a pleasure, and I think what you're doing is fantastic, and I think it is really important to empower patients to be able to learn about what's going on and what the options are, and to be able to approach their GP who may not know a lot and say, look, I've been reading about this and I'm quite keen to try this, and what do you think? And I think that's a really, in this day and age of our health system being as stretched as it is, I think that there is a lot that we can all do about our own health. And I think having your website gives people a lot of information that's very helpful for them to then take and talk to the GP about.
Thank you. Thank you. Yeah. All right. Thank you, everyone.
Okay.
Thanks.
Okay. See you. Bye, Sarah.
Bye.
Okay.